Hello everyone. In continuation with our chapter in rheumatology, which is rheumatoid arthritis, in the last session we had learned about the etiology, the pathogenesis and the articular manifestations of RA. So in continuation, today we will be discussing about the extra-articular manifestations, diagnosis and management of rheumatoid arthritis. Okay, so let's begin. So what are the extra-articular manifestations of rheumatoid arthritis? So RA can literally affect any part of the body apart from the joints, right? So firstly, it can present with constitutional symptoms. Constitutional symptoms include low-grade fever, weight loss, and myalgias. Very rarely, there can be some amount of lymphadenopathy as well. But that is a very rare symptom. Then, as far as the skin is concerned, you can have development of something called as rheumatoid arthritis nodules, okay? So, you can have development of subcutaneous nodules. Okay, so what are the characteristic features of these RA nodules? These nodules are predominantly subcutaneous in nature, right? So, they are freely mobile nodules which are usually found in the subcutaneous plane. So, they are found in the extensor aspect of the limbs. They are found in the extensor aspect of the limbs. They can also be found where the tendons meet the bone, for example, over the Achilles tendon. Okay. So, they are usually firm, mobile nodules. Okay. Sometimes they may be attached to the underlying bone as well. Right, so this is how you would describe an RA nodule. So RA nodules usually correlate with the disease activity. So if the rheumatoid arthritis is not well controlled, you can have diffuse nodulosis. Histopathologically, how will the nodules appear? The nodules will comprise of a central region which mainly comprises of a central core surrounded by epithelioid cells. Okay, the central core predominantly comprises of a lot of eosinophilic material and it is surrounded by epithelioid cells and rim of lymphocytes. Okay, so there will be a central clearing comprising of eosinophilic material surrounded by epithelioid cells and a rim of lymphocytes. Okay, so this histopathologic examination of a nodule is very similar to another disease which is called as granuloma annulare. Okay, so this is very similar to granuloma annulare and you cannot histopathologically differentiate an RA nodule from the same. Okay, so it mainly comprises of a central core which is comprising of eosinophilic material surrounded by epithelial cells and rim of lymphocytes. So there is one drug which can paradoxically increase these RA nodules and that drug is methotrexate. So methotrexate, which is used in the management of rheumatoid arthritis, can also paradoxically increase the nodules and these nodules can be found in the lungs as well. Okay, fine. So that is about RA nodules. Secondly, in the skin, rheumatoid arthritis can be associated with a secondary form of vasculitis which can affect either the small or the medium vessels. If the small vessels are involved, you can present with purpura. If the medium vessels are involved, it can be associated with vasculitic ulcers or gangrene. Okay, so this is about the skin manifestations in rheumatoid arthritis. Now let us move on to the ocular manifestations. Rheumatoid arthritis can be associated with episcleritis and scleritis. Okay, so these are usually painful conditions or painful red eye can be present. And in severe cases, the sclera can get thinned out and it can perforate and this is what we call as scleromalacia perforans. Okay, so the most dreaded ocular complication of rheumatoid arthritis is scleromalacia perforans mainly because of the thinned out sclera. Alright, fine. Then let's move on to the pulmonary manifestations. So amongst the most common pulmonary manifestations is that rheumatoid arthritis can cause pleuritis. Rheumatoid arthritis can be associated pleuritis with or without effusions. Okay, So rheumatoid arthritis can be associated with pleuritis, and if at all an RA patient develops a pleural effusion, the pleural effusion will have a high LDH. It will have a high LDH and a very low glucose. So pleural fluid glucose less than 40 or less, very low glucose is a characteristic feature of rheumatoid arthritis pleural effusion. Okay. So similar to how we discussed nodules in the skin, it can be associated with nodules in the lung as well, and a specific named syndrome that you should be aware of is called as the Kaplan syndrome, which is basically found in coal workers' pneumoconiosis. So pneumoconiosis along with RA nodules, pneumoconiosis along with RA nodules is what we call as Kaplan's syndrome. Okay, fine. Then RA can be associated with interstitial lung disease. And what is the type of interstitial lung disease that you have? So you remember that this is an exception. We had discussed this in the ILD chapter as well. So RA is one of the only connective tissue disorders which is associated with the usual interstitial pneumonia pattern of ILD, UIP pattern, while most of the other CTDs are associated with an NSIP pattern of ILD. Okay. So in this UIP pattern, what will you find? You will find bilateral lower zone honeycombing. You will find bilateral lower zone honeycombing and traction bronchiectasis. Okay. So this is your UIP pattern of ILD in rheumatoid arthritis. Then RA can be associated with airway disease as well. They may present to you with recurrent episodes of obstructive airway disease. And in a more severe form is called as a constrictive bronchiolitis, which has a very poor prognosis. What is that form? That is your constrictive bronchiolitis, which is having a very poor prognosis, a type of airway disease which you find in RA. So when you speak about the pulmonary manifestations in RA, you remember pleuritis, pleural effusion, nodules, ILD, UIP pattern and constrictive bronchiolitis. Okay. So this is how RA affects the lung. Then what are the manifestations in the heart? So rheumatoid arthritis can affect the pericardium and it can cause pericarditis, and some amount of pericardial effusion can also be present. So pericarditis is usually going to present as a sharp chest pain. And on auscultation, you may find evidence of a triphasic pericardial rub. Okay, then RA can be associated with conduction disturbances, right? So some of these nodules can also go and destroy the conduction system in the heart and can be associated with very severe bradycardias, which may require a pacemaker as well. Rheumatoid arthritis, if it affects the myocardium, it presents with myocarditis. Myocarditis is going to present with symptoms of heart failure. Okay. It's going to present with symptoms of heart failure, pedal edema, abdominal distension, orthopnea. Then, RA is a immune-mediated process which has a high propensity for atherosclerosis. In fact, rheumatoid arthritis patients can develop atherosclerosis 10 years earlier as compared to their normal counterpart. Because of this high risk of atherosclerosis, it's very important that every RA patient undergoes a proper screening for diabetes, hypertension and other risk factors including dyslipidemia. Okay, so they are predisposed to atherosclerosis and they can develop a coronary artery disease and increased risk of myocardial infarction. Okay, fine. So this is how RA affects the heart. Then another very important hematological manifestation of rheumatoid arthritis is what we call as the Felty syndrome. Okay, so in this Felty syndrome, a patient of rheumatoid arthritis develops severe splenomegaly with cytopenias. This is what we call as Felty syndrome. Okay, so the cause often is unknown. So if a RA patient has developed cytopenias and splenomegaly, you think of Felty syndrome. Right, so the treatment of Felty syndrome predominantly involves treatment of the underlying rheumatoid arthritis itself. But in certain cases, if the neutropenia is very severe, you may have to give them colony stimulating factor, which is your GCSF, may be needed to bring up the total counts. Okay, so that is your Felty's syndrome. Then Rheumatoid arthritis can be associated with a secondary Sjogren's syndrome. So you may have RA patients complaining of dry eyes and dry mouth, and your SSA, SSB antibodies may be positive. Okay, so this is how RA can have a secondary Sjogren's syndrome. In those cases, you may have to treat them with symptomatic treatment as well, like your triad replacement or salivary replacement and so on. Then, RA over a long time predisposes to secondary amyloidosis. So, these amyloid deposits are especially found in the kidney and they can present with a nephrotic range proteinuria. Okay, so they can present with amyloidosis and a secondary nephrotic syndrome. This amyloidosis predominantly affects the kidney. Okay, fine. Then, rheumatoid arthritis can also cause arthritis in the cricoarytenoid joints. Okay, so the cricoarytenoid joints, if they are involved, how will they present? They are going to present with dysphagia. It may present with dysphagia. It may present with hoarseness of voice. Okay, so it may present with dysphagia. It may present with hoarseness of voice. So that occurs mainly because of inflammation of the cricoarytenoid joint. If the ossicles of the ear can also be involved by rheumatoid arthritis, then this can cause tinnitus. It can cause some form of conductive hearing loss as well. Okay, fine. And lastly but not the least, we have something called as LGL syndrome, which stands for large granular leukemia or lymphoma. So this LGL leukemia lymphoma is a type of malignancy which usually occurs in chronic rheumatoid arthritis, especially in individuals who have an underlying Felty syndrome. Okay, especially in individuals who have an underlying Felty syndrome, you can develop this LGL type of a secondary malignancy. Fine. Then, what about the atlantoaxial involvement? So, rheumatoid arthritis also has a predisposition to involve the atlantoaxial joint. So, if the atlantoaxial joint is involved, it can cause direct compression of the spinal cord and it can result in quadriparesis. Hence, it becomes very, very essential that every RA patient who complains of neck pain always get an MRI done to look at your atlantoaxial dislocation, and atlantoaxial joint dislocation can result in severe quadriparesis. Alright, fine. Apart from this, certain other CNS manifestations can also be present. RA can cause, in rare cases, it can cause myelitis, and RA can also be associated with mononeuritis multiplex, especially if there is an underlying RA associated secondary vasculitis, then you can have mononeuritis multiplex because of involvement of the arteries that supply the multiple non-contiguous nerves. Okay, fine. So these are all the huge list of extra-articular manifestations which can be found in rheumatoid arthritis. So let us just revise that again. So what all have we learned? We have learnt about the constitutional symptoms, right? We have learnt about RA nodules, and we have learnt about vasculitis, and then we have learnt about scleromalacia perforans. Pulmonary manifestations, we have pleuritis, nodules, ILD, which is a UIP pattern, airway diseases. Then amongst the manifestations in the heart, we have learnt about pericarditis, conduction disturbances, myocarditis, risk of early atherosclerosis, Felty syndrome. We have learnt about Sjogren's, which is a secondary Sjogren's disease, amyloidosis, cricoarytenoid arthritis, LGL syndrome, atlantoaxial dislocation, and we have learnt about the neuromuscular manifestations as well. Now, what is the classification criteria for rheumatoid arthritis? So, we have an ACR classification criteria for RA. This is not a definitive diagnostic criteria, but it is predominantly used as a classification criteria. So, this helps us understand whether the patient has a possibility of having rheumatoid arthritis or not. So, what are the parameters that this ACR criteria looks into? One is joint involvement, right? And it is scored based on the number of joints that is involved. So, only one large joint is given a score of 0 because rheumatoid arthritis involves bilateral symmetric small joint involvement. So 2 to 10 large joint, it is given a score of 1. But if there is small joint involvement, as you can see, the score value is much more, and if the number of joints go on increasing, 4 to 10 small joints is 3, more than 10 joints is 5. Then it takes into account the serology. If both RF and anti-CCP, which is anti-cyclic citrullinated polypeptide, both are negative, it is 0. Low positive titers is 2 and high positive titers is 3. It also takes into account the acute phase reactants, your CRP and ESR, and it takes into account duration of symptoms. If the duration of symptoms has been there for more than 6 weeks and is given a score of 1. Okay, so this is your ACR classification. You do not need to know it by heart, but you definitely need to know what are the parameters that it takes into account. So joint involvement, serology, acute phase reactants, and duration of symptoms. Fine. So now let us move on to the diagnosis of rheumatoid arthritis. So under the laboratory evaluation, so when you look at the basics, you find the CBC. Most often the CBC will be normal. Sometimes you may have evidence of mild anemia, which is predominantly an anemia of chronic disease. The total counts are usually normal. If the total counts decrease, then it may herald a Felty syndrome. It may herald a Felty syndrome. Since this is a chronic or a long-standing disease, you may find hypoalbuminemia. And since this is an inflammatory process, the inflammatory markers ESR and CRP will be elevated, right? Then you have two important serological markers which are useful in the diagnosis of RA. One is a rheumatoid factor and other is the anti-CCP. Okay, so let us look at rheumatoid factor. So rheumatoid factor has a sensitivity of around 80% and a specificity of around 86%, right? So what this means to say is that not all our rheumatoid arthritis patients may have an RF positivity, and not all patients with RF positivity are a definite rheumatoid arthritis. Okay, so that is why rheumatoid factor is only a screening test, but it is not a confirmatory test for the presence of rheumatoid arthritis. So what are the other conditions in which rheumatoid factor can be positive? You will have to remember a few conditions. So this rheumatoid factor can be positive in Sjogren's syndrome. It can be positive in certain cases of SLE. It can be positive in certain cases of infective endocarditis as well. That is the reason why it is not always a definitive criteria for the diagnosis of rheumatoid arthritis. Then the next serological marker that is used is anti-cyclic citrullinated polypeptide or anti-CCP, which has a low sensitivity but it has a higher specificity, so it is more than 90% specific, right? So if this is present, then you can most definitely say that this is a rheumatoid arthritis, definitely. Fine. But the disadvantage of anti-CCP is that though you may have large titers, the titers do not correlate with disease activity. So this is about the various laboratory tests which can be done for the definitive diagnosis of rheumatoid arthritis. Now let us look at what are the X-ray features. Now we have learned in the pathogenesis of rheumatoid arthritis that RA usually causes destruction and erosion of the joints because of Pannes formation. So what all can you see in the X-rays? So you will find evidence of erosions. Can you see in this X-ray that you find that there is evidence of erosions? The bones are broken down. Then the joint space will be narrowed because of cartilage destruction and synovitis. You can see that the joint spaces are narrowed, right? There is narrowing of the joint spaces and there can be erosions as well. And in the later stages, you may find evidence of deformity. So here you can see that there is evidence of deformities here. So this is in the later stages. Another very important feature which you can find in the X-ray is the presence of juxta-articular osteoporosis, right? So just surrounding the joints, you may find evidence of osteoporosis and osteopenia. So these are the X-ray features which you may find in a patient with rheumatoid arthritis. Erosions, decreased joint space, presence of deformities, presence of juxta-articular osteoporosis. Now, let us move on to the management. Okay, so management of RA predominantly is brought about by the group of drugs that we call as the DMARDs. Okay, So what are DMARDs? DMARD stands for disease modifying anti-rheumatic drugs. Okay, so DMARD stands for disease modifying anti-rheumatic drugs. So now with the advent of newer drugs, DMARDs are classified into 3 types. So we have CS DMARDs, which are conventional synthetic DMARDs. Conventional synthetic DMARDs. Then we have TS DMARDs, which stands for targeted synthetic DMARDs. And B stands for biologics. Okay, so rheumatoid arthritis management mainly is brought about by 3 groups of drugs. So we have the conventional drugs, then nowadays we have a targeted drugs and biologics, which are the newer drugs in the armamentarium for the treatment of rheumatoid arthritis. And always remember that one motto in the management of rheumatoid arthritis is something called as treat to target. Okay, it is called as treat to target. So if you go through the ACR criteria, you will find that there are certain targets which are achieved. Okay, so you might have to reduce the tender joint count to less than 1, swollen joint count to less than 1, and so on. So these are what are the certain defined targets which are put forth for the management of RA. So the motto in the management of RA is treat to target. So you keep the patient as comfortable as possible, reduce the number of tender joint count, reduce the number of swollen joint count, keep them pain free, and reduce the extra-articular manifestations. Fine. So now we will be going through the list of certain drugs along with their common doses and common side effects of the drugs. Right. So first we start with your CS DMARDs. So this is your conventional DMARDs. What are the drugs that are used? So first line treatment of rheumatoid arthritis involves the use of conventional DMARDs. So first is the most important, which is Methotrexate. Okay, which is Methotrexate. Methotrexate is given as a weekly dose. So Methotrexate is given as a weekly dose. It inhibits the folic acid production. It's given in a dose of 7.5 mg to 25 mg per week. So along with this, you also have to replace with folic acid. You also have to replace with folic acid once a week. Okay. So what are the side effects of Methotrexate therapy? So whenever a patient is being started on Methotrexate, you have to monitor their liver and renal functions. You have to monitor their liver and renal functions. And over a long course of time, or if you take it in an overdose, you have been prescribed for a weekly dose, but some patients may not understand that and they may just take it on a daily dose, then it can cause a severe bone marrow suppression. Very, very important. That's why you always have to explain the patients about the toxicities of Methotrexate. Okay, some form of idiosyncratic pulmonary toxicity has also been described, right? It has also been described, and because these are DMARDs, there is an increased risk of infections as well. And always remember that Methotrexate is a teratogenic drug, so you do not prescribe that in pregnant patients. Okay, so the first drug and a very, very effective drug has been Methotrexate. Then the other DMARD is your Leflunomide. So Leflunomide is a newer drug which is being used especially in conditions where Methotrexate is not tolerated, or if you have an underlying ILD where you suspect that the Methotrexate may not be tolerated, then you may have to give an Leflunomide, or Leflunomide can also be given as an add-on therapy or a switching therapy. So this is given at a dose of around 20 milligrams per day. And remember, this important side effects include hepatotoxicity, diarrhea, alopecia, and peripheral neuropathy, right? So these are the important side effects of Leflunomide. Then the third drugs which are used amongst the conventional synthetic DMARD includes your sulfasalazine. Sulfasalazine is a sulfa drug. It is a sulfa drug. So very, very importantly, always rule out sulfa allergies in a patient before administering sulfasalazine. The other condition where sulfasalazine has been found to be very, very effective is your spondyloarthropathies. Okay, so this is given at a dose of around 500 milligram BD, and SAS is generally a safe drug. only it causes GI upset, it may cause GI upset, it may cause rashes, and in certain conditions it may cause DRESS syndrome, which is basically a drug-related eosinophilia with systemic symptoms. Okay, in DRESS syndrome they can develop a severe skin rash and they may develop liver derangements as well, right? So this is a rare side effect, but SAS is usually a well tolerated drug. And the last of the conventional synthetic DMARDs that we should be aware of is your hydroxychloroquine, which is basically an anti-malarial agent used, and it's a very commonly used drug. This is given at a dose of around 200 to 400 milligram daily, and the most important side effect or what we have to be watching out for in HCQ is it can cause macular degeneration. It can cause retinopathy and macular degeneration. So that is something that we have to keep watching out for, right? So that is one of the most common side effects. So this is about your conventional DMARDs. So remember Methotrexate, Leflunomide, sulfasalazine and hydroxychloroquine. You do not have to remember all the doses, remember the major side effects of these drugs. So the next group of drugs that we come to is your targeted synthetic DMARDs. So what do they target here? Here they target the main pathway, which is the JAK-STAT pathway. Okay, so we have JAK inhibitors which are part of your targeted synthetic DMARDs, which form the second line treatment in the management of RA. So three drugs that we have to know is tofacitinib. Tofacitinib is a JAK 1, 2 and 3 inhibitor. Right, so tofacitinib is given at a dose of around 5 mg twice daily. So always remember that any of these JAK inhibitors, there are certain important things that you have to consider. So whenever you are starting a JAK inhibitor, there is increased risk of reactivation of chickenpox. There is an increased risk of reactivation of chickenpox and or what we call as shingles, right? So you have to vaccinate them prior to starting a JAK inhibitor. So in India now we have the Shingrix vaccine available. So please vaccinate them prior to starting your JAK inhibitors. So there is an increased risk of infections like TB and shingles. And also remember there is an increased risk of thrombosis, increased risk of malignancy and dyslipidemia, right? So always ask about history of any prior malignancy as well, because there is a risk of reactivation of malignancies, risk of thrombosis in these patients. Okay. So tofacitinib is JAK 1, 2, 3 inhibitor. Baricitinib is JAK 1 and 2 inhibitor. And upadacitinib is JAK 1 inhibitor. Okay. The three drugs are tofacitinib, baricitinib and upadacitinib. Alright. Clear? Out of which the maximum risk of cytopenias is predominant with baricitinib. Right? So we have finished your conventional DMARDs and we have finished your targeted synthetic DMARDs. Now let us move on to the biologics. The biologics which we predominantly use are your TNF-alpha inhibitors. Okay, so the drugs include adalimumab, etanercept, infliximab. So all of these drugs, you try and remember the common side effects. Most of them are given as a weekly or a once in 2 weeks regimen. So always remember there is an increased risk of TB reactivation. So prior to any administration of your TNF inhibitors, always rule out latent tuberculosis, and if there is evidence of latent tuberculosis, you will have to treat them, right? So what is the meaning of latent tuberculosis? So you do a IGRA or a TB quantiferon gold assay, and if it comes positive, you may have to treat them for latent tuberculosis with a dual regimen of rifampicin and INH for at least 3 to 6 months. Okay, so that is a very important side effect that you have to remember. Apart from that, many of these inhibitors, TNF inhibitors, can have risk of demyelination and risk of infusion reactions, especially with infliximab. So the most commonly used ones are adalimumab and etanercept. Okay. Now, despite all these, there still continues to be a disease which is refractory to treatment. So relapsed or refractory RA, or very severe forms of ILD, or very severe forms of nodulosis, or very rapidly progressive rheumatoid arthritis. In these conditions, certain other group of biologics can also be used, which includes your rituximab. Rituximab is an anti-CD20. Then you can use Abatacept and Tocilizumab. Tocilizumab is your anti-IL-6, right? So these drugs are your last resort drugs. They are your last resort drugs, especially in your relapsed or refractory rheumatoid arthritis. Okay, fine. So the most commonly used of this is a Rituximab based therapy, which is given as 1 gram IV on days 1 and 15, and then it is given as a maintenance regimen every 6 months. So with Rituximab therapy, remember that because this is B cell depleting, there is a high risk of reactivation of infections, predominantly hepatitis B, tuberculosis, and hence all of this screening has to be done prior to initiation of Rituximab. There is also an increased risk of PML. Okay, so this is your last resort therapy for rheumatoid arthritis. So what all have we learnt in the management of rheumatoid arthritis till now? So we have learnt about conventional synthetic DMARDs, targeted synthetic DMARDs, and biologics. So what is the target whenever you speak about the management of rheumatoid arthritis? What should be our aims? So our aim should be a tender joint count of less than 1. When you examine the patient, how many tender joints are present? Then swollen joint count of less than 1. Inflammatory marker should be less than 1. Then we have something called as a physician global assessment scale, which is already available in the apps or in the mobile phones, where you do a global assessment scale. You put down certain parameters and you see the total score. That also should be less than 1. So this is how you treat or target a patient for rheumatoid arthritis 2B. Or you do a simplified disease activity staging, and this score has to be less than 3.3 at the end of your treatment to keep the patient comfortable, right? So this is about your targets. Now, what are the other parameters that you want to see in the management of rheumatoid arthritis? You always have to consider that these patients can be at a risk of osteoporosis, right? Because many of these patients would have got some amount of systemic glucocorticoids during the management of their rheumatoid arthritis, especially during the acute episodes, right? During acute episodes, there is a role of systemic glucocorticoids, there is a role of intra-articular glucocorticoids as well. So there is an increased risk of osteoporosis in these patients. So always ensure that the osteoporosis is treated well. And then you will also have to monitor them for the side effects of DMARD therapy. So always monitor them for the side effects of DMARD therapy. Then thirdly, always monitor them for an increased risk of infection. So vaccinate them early, especially if they're going to get JAK inhibitors. You vaccinate them against shingles, treat them for LTBI before the initiation of biologics and so on. Vaccinate them with your influenza vaccine and your pneumococcal vaccines as well, right? So this is how you manage the patient and also look for the other overall comprehensive evaluation and management of RA patients, right? So apart from all of this, you have to advocate a healthy lifestyle. RA patients are advised to undergo regular physical activity and also take a good diet. Okay, fine. In very, very severe cases, if there is a lot of deformities, they should also be helped with rehabilitation. There are certain splints which are available so that the joints can be put back into place, as well as certain corrective surgeries can also be done for improving the deformities. So this is how you holistically manage a patient of rheumatoid arthritis. So with this, we've come to the end of our chapter on rheumatoid arthritis. Thank you.